All right, today we're tackling vestibular migraine. Now, this is the single most common cause of recurrent, spontaneous vertigo, and yet, somehow, it's also the diagnosis that almost everyone misses. So in this explainer, we're going to uncover the single biggest reason why and how you can start diagnosing it accurately.
5 to 8 years. Just think about that. Imagine waiting that long for a correct diagnosis. Well, that's the reality for the average patient with vestibular migraine. And this isn't some rare, obscure condition. It affects about 1% of the population. So what's really going on here?
Well, this timeline really shows that frustrating journey these patients are on. I mean, they're bounced between specialists, they're given labels like anxiety or just a vague inner ear problem, and you can imagine they often lose faith in the whole system. Each one of these steps represents years of debilitating symptoms without a clear explanation or, any effective treatment. Now, to put this all into perspective, vestibular migraine has a lifetime prevalence of around 1%. That makes it the second most common cause of episodic vertigo, right behind BPPV or benign paroxysmal positional vertigo. So, given just how common it is, this diagnostic delay is a major clinical issue we really need to solve.
So why is it missed so often?
Well, it really comes down to one single, deeply rooted clinical assumption. This right here. This is the barrier that prevents millions from getting the right diagnosis.
And here's the central question. Do you need a headache to diagnose a migraine? I think for a lot of us, the words migraine and headache are practically synonymous. But what if that core belief is just wrong?
Look at this number, over 30%. That's the percentage of patients with definite, by-the-book vestibular migraine who never have a headache with their vertigo episodes. Just let that sink in. If you require a headache for the diagnosis, you're going to miss 1/3 of these patients right from the start. So here's the crucial point. The official diagnostic criteria do not require a headache. The presence of other migraine features, specifically photophobia, that's sensitivity to light, and phonophobia, sensitivity to sound, during an episode is actually enough. This is exactly where the diagnosis gets missed so often, by equating migraine with headache. Fortunately, we have a really clear evidence-based solution. So let's move on to the formal diagnostic criteria from the Bárány Society and the International Headache Society, and we'll see how this builds a framework for an accurate diagnosis you can make right at the bedside. It really is a simple 4-part checklist you can use. First, have you had at least 5 episodes of vestibular symptoms, like vertigo, that last between 5 minutes and 72 hours? Second, do you have a current or past history of migraine? Third, do you get a migraine feature, like a headache or just that light and sound sensitivity in at least half of the episodes? And finally, of course, making sure it isn't better explained by something else. And this flowchart just shows how those 4 criteria work together in practice. By following these pretty simple steps, you can confidently move from just having a suspicion to a definite diagnosis of vestibular migraine. Okay, so now that we have the formal criteria down, let's translate that into a memorable clinical signature. What does the patient's story actually sound like when they're sitting in front of you in your clinic room? Here is the pattern. The patient will describe these recurrent attacks of vertigo lasting minutes to hours. They'll mention being sensitive to light or sound. You'll often hear about known migraine triggers, things like poor sleep, stress, or hormonal changes. And critically, when you examine them between episodes, everything is normal. That pattern is vestibular migraine, even if they've never had a headache in their life. Now, a common point of confusion is with Meniere's disease. That's another inner ear condition that causes vertigo. The key difference? It's the hearing. The decisive test here is audiometry. If the hearing is normal and those migraine features are present, you should be thinking vestibular migraine. If there's documented low-frequency hearing loss, then you start thinking Meniere's. So let's wrap this up by summarizing the most critical, practice-changing points from this explainer. This insight is incredibly powerful for patients. A lot of them have been told for years that their ears are fine, and that just leaves them feeling dismissed. Giving their condition a name and explaining it as a brain-based sensitivity, it restores legitimacy and it really empowers them to engage with their treatment. So, the crucial points to remember are these. Vestibular migraine is the most commonly misdiagnosis out there. Headache is not required. sensitivity to light and sound alone are totally sufficient. And finally, if you see a patient with recurrent vertigo, classic migraine triggers, and a normal exam, you are very likely looking at vestibular migraine.
So, what's next? Well, in the second part of this explainer series, we're going to dive even deeper into the differential diagnosis. We'll sort out VM from its mimics like Meniere's and BPPV, and we'll cover the specific investigations that can help clarify the whole clinical picture.
Thank you so much for your time. For more detailed clinical guides and patient resources, please go ahead and visit the website on your screen. And if you found this explainer valuable for your practice, please subscribe so you'll be notified of future content.